Hi, everybody, and welcome to the October edition of the Research Roundtable with Dr. Karen Herbst, Chief Medical Officer for Lympha Press. I'm Brenda Viola with Lympha Press. Happy to welcome you and to sort of kick things off tonight, but we have such a great topic and such a great guest. Dr. Nicholas Pennings is one of the most brilliant minds when it comes to obesity. He's devoted his career to the study of obesity, and he is board certified in family medicine and obesity medicine, recognized as a master fellow of the Obesity Medicine Association, a fellow of the American College of Osteopathic Family Physicians, and a fellow of the American Academy of Family Physicians. He joined the faculty of the Campbell University School of Osteopathic Medicine in 2013, served as director of the Campbell University Health Center for over 11 years, and chair of family medicine for over 8 years. He contributes to continuing medical education in obesity medicine for clinicians in practice through his role as the executive director of clinical education for the Obesity Medicine Association. I could go on and on and on, but we want you to tell us who you are. Let us know who has logged on, who's joining us tonight. As you know, this will be a one-on-one conversation with Dr. Herbst and Dr. Pennings, but also we'll take your questions and we will weave them in as we have gaps in the conversation. So put your questions in the Q&A. And with that, I am going to disappear and I will say, let's let the two brilliant minds discuss this amazing topic.
Thank you, Brenda. And welcome, Dr. Pennings. So nice to have you. I want to just open up this discussion by just asking you, what is the definition of obesity to you?
To me, well, that is, I think that's a confusing topic because, the standard is based on BMI, so which is a ratio between your weight and your height. And it's a calculation that's done. But that calculation doesn't say anything about gender, age, race, body fat distribution. You could be extremely muscular and have a BMI that's in the obesity range. You could have a lot of excess adipose tissue, a lot of excess fat in the body, and have a normal BMI. And that fat may be dysfunctional and metabolically active, where it's contributing to diabetes and hypertension or other diseases. And I think that's really, in my mind, what's important. It's not just what that number on the scale is. It's not what that BMI is. It's what is the impact on metabolic health and quality of life, as well as your ability to function and mobility, and on your psychology as well, because we see anxiety, we see depression, we see other mental illnesses associated with excess weight. So in my mind, it's not a BMI. It's really where excess weight causes some sort of pathologic dysfunction. That's where I see obesity beginning.
I like that definition. That makes sense because it's descriptive, but it's functional, and that's the most important thing. What about the different types of obesity that you see? Because there's lipodystrophies, there's metabolic obesities, there's lipedema, lymphedema. What range of obesities do you see?
I see a lot of patients with lipedema, but I see all types of obesity. And so when we look at, excess weight and how it impacts the body, we at the Obesity Medicine Association, we tend to focus on whether there is what we call adiposopathy, which is where the fat tissue becomes dysfunctional, and that's the beginning of metabolic disease, the diabetes, hypertension, cardiovascular disease, fatty liver disease, all these metabolic dysfunctions, type 2 diabetes in particular, that cause a lot of health issues. But the mass effect can be there as well, and that's where we see sleep apnea, where excess weight around the neck is narrowing the airway and blocking airflow. where excess weight is putting stress on your joints, particularly your hips and your knees, and those lead to joint replacements and things like that. It can even excess fat around the kidney can compress the kidney and raise your blood pressure. But also, and where lipedema falls is really a little bit unclear. Is it a metabolic disorder? Is it a mass disorder? And it's really both, right? Because the pain and the that we see with it, the sensitivity, that's inflammatory driven most likely, right? So that's the more of a metabolic effect, but then the mass effect results in the immobility and also stressing the joints and causing infections in the folds of the skin. So they're kind of it's an interesting, it's kind of an overlapping, both a dual metabolic and structural problem.
Mhm. So you mentioned that lipedema was inflammatory. There's a couple papers out that go against that, and there's a number of papers that support that. And I don't think we have the exact answer, but if you were to compare inflammation in lipedema versus obesity, what would you say? Would you say they were similar?
No, because we see inflammation causing metabolic dysfunction, right? So the fat cells release something called cytokines and adipokines, and these are agents that can trigger inflammatory responses throughout the body. And that's not what we see with lipedema. We don't see metabolic dysfunction very often. We don't see diabetes, hypertension, dyslipidemia. We don't most women with that. And I think that's because the fat cells in lipedema still function fairly normal from an ability to store fat in a safe way. So we need fat tissue, right? You mentioned lipodystrophy. Lipodystrophy is a condition where you can't form fat cells, and what happens there is right away you get metabolic dysfunction. You get, high sugars, you get high triglycerides, you get fatty liver, and really it's a very serious problem. So we need fat cells, and I think of our fat cells as sort of like a sponge, right? So when we consume calories, we can use them, we can store them small amount as glycogen, but the rest really has to go into the fat cell, and those calories go in and out of the fat cells, and it works very well like a sponge, can take up some water, can release some water. But when the sponge gets saturated, when you can't add any more water to it, it spills over, right? And so the same thing happens in the fat cells when they reach their capacity, then they start spilling over. And what does that mean? That means we get circulating free fatty acids in the body that are toxic to the body, and that leads to the metabolic dysfunction, the high triglycerides, the high blood sugars, all that. We don't really see that with lipedema. So we can see that expansion and seemingly a lot of expansion, as we all know, that can happen with lipedema. Um, so it seems to hold on to that, but I think that the inflammation there is local inflammation, that is around the tissues itself, not in the general circulation that is causing metabolic disease.
That's really interesting because a group out of Italy was looking for mast cell inflammation and lipedema, and they looked in the blood and they couldn't find it. So they went in and did biopsies of the fat tissue and were able to identify higher histamine levels in the biopsies in women with lipedema versus controls. So that makes sense, at least for mast cells, but I imagine it would make sense for other immune cells as well. I This is kind of it's another question about fat, but one of the things that I've been looking at a lot lately is perivascular fat tissue. And that is kind of an ectopic fat. But I know that you get fat around veins, for example, in venous disease. What kind of fat is that? Would that be an inflammatory type of fat?
Well, it's ectopic fat, right? Ectopic fat is fat where it's not supposed to be. And we see that around the heart. That is one of the consequences and one of the cardiovascular consequences. So it's not just high circulating triglycerides or cholesterol that is causing the plaque in the arteries of the heart. There's actually an effect so fat builds up around the heart. And if you look at a heart in someone with obesity, you will see fat all around the blood vessels, just kind of caked all around the outside of the blood vessels. But that fat has a direct effect on the vessel itself. It reaches and causes endothelial dysfunction, the dysfunction of the inner lining of the blood vessel, and contributes to cardiovascular disease that way. So there is this effect that actually, goes through the whole wall of the vessel, affecting the arteries of the heart. And we know that arteries are much thicker than veins.
Mm-hmm.
So the ability of that fat to traverse the wall of the blood vessel is probably much easier. I haven't seen anything specifically on venous disease, but it would make sense that that would be having a direct inflammatory effect on the veins.
Mm-hmm. And I wonder if it's vice versa too. Inflamed veins may instigate the growth of fat, and then fat in turn feeds back into the vein and generates more inflammation, and it becomes a vicious cycle.
Yeah, it may be very well bidirectional because don't really know why all this fat forms around the vessels of the heart either, right? I mean, when you look at it, it's specifically around the vessels of the heart. So there probably is a crosstalk there that is affecting them.
So the fat that we're talking about so far could come from lifestyle, so too many calories in, too little energy expenditure out. But then it can also come from just inflammation within a blood vessel we've talked about. And then what about lymphedema, for example, when you get excess fat growth in lymphedema, what's going on there?
Right. So, when we look at patients with lipedema, we see that increase in tissue edema. It's boggier, it's heavier. It is uh, you can feel the fluid. It doesn't necessarily compress like it does with regular lymphedema. So when I see lymphedema in patients that have, say, heart disease, that's going to be very much, it's different because does something called pitting. You put your thumb on it and you create an indentation. And so that tells you that a lot of that fluid is really kind of outside the cellular space, the intracellular space. It's more at the surface of the skin, which is not what we see with lipedema. It seems to be more embedded in the tissue itself. But I don't really see lymphedema in patients with obesity until that BMI gets very high, but also more commonly if they have underlying cardiovascular disease. So if they have some sort of heart issue, that's what's going to be leading to the fluid buildup in their legs. That's what's going to lead to the lymphedema, especially when that's more chronic in nature. Then you get this buildup of the lymphatic fluids in the legs. But like I said, I don't see that until the BMI gets much higher, or they have significant cardiovascular disease.
So that's really interesting. And we were talking about this uh, before coming on today, that in the literature, there's this question on whether there is edema and lipedema. And Shelley Krasinski's done some nice work showing that there is by MRI, but it's not as much as, it's not free flowing fluid like in lymphedema. It is within that interstitial space. It may be bound up to the glycosaminoglycans, but the Germans say that any edema that there is in lipedema is from obesity. It's from metabolic obesity associated with lipedema, but not the lipedema itself. What are your thoughts on that?
Yeah, and I would say that if it's present from obesity, it just presents very differently. It's really much more on this, more closer to the surface of the skin and not within that interstitial tissue, interstitial fluid within the tissues. To me, it feels very different when I'm examining a patient with lipedema versus a patient with obesity and underlying lymphedema.
So as adipose tissue grows on a woman with lipedema, it's not causing the same mass effect as metabolic obesity would, because you said there's two reasons why how that fat can affect the body, either by cytokine release or mass effect. So do you think that if edema appears in lipedema, that it's more mass effect then?
Well, um, I would say that it's a different inflammatory response, right? It seems to be just localized inflammation, not systemic inflammation. So we're not seeing it. So those cells are behaving differently than other fat cells, which we know to be true. We know that they're just their distribution, their pattern, their response to, dietary interventions or physical activity, they behave differently. And so, from this inflammatory point of view, I believe they behave differently as well because the inflammation seems to be more localized, and I think that's what contributes to the pain that occurs with lipedema, the achiness, the heaviness, the just the discomfort that women feel in their legs.
So speaking of fat that can grow around blood vessels, did you see Saverio Cinti's paper, his electron microscopy paper on lipedema, where he showed that endothelial cells were damaged, and he'd never seen anything like it in his 45 years of work on electron microscopy. So
No, I
whole
hadn't.
endothelial cells fell out
Uh-huh.
and were damaged. And we talk about like leaky vessels. You can get leaky vessels, I would say, with any kind of inflammatory condition, but he basically was able to confirm that by showing that whole endothelial cells were just gone. They dropped out somehow.
Really?
Yeah, you should take a look at that. That would be super interesting to get your opinion on it. And
Yeah.
it correlates to a question we have. This is from Susan McCoy. She said, if fat surrounds veins, how can they leak? Same question for leaky gut syndrome.
Um, well, I mean, the not leaking is based on the integrity of the cell of the vessel wall. So the the fat that around it doesn't seal it. It just is present there. And if um I think if fluid were to leak out of a vessel, it would be um, you know, it would be able to, and I don't think the fat would suppress that. But the leaking of vessels is usually much smaller vessels. I was talking about much larger vessels,
Mhm.
arteries and arterioles, and you're going to get to the much smaller arterioles and capillaries that are leaking. That's where the fluid usually leaks out of, not out of the larger arteries, but it's the fat builds up around the larger vessels.
Thank you for that question, Susan. So, what are some like common treatments for uh, excess adipose tissue that you use in your practice?
When I approach a patient that has excess weight to lose weight, we need to take a comprehensive approach. There's no sort of just do this or that. We need to focus on nutrition, and nutrition should be, creating a dietary intervention that will reduce calories, that will promote health, that will provide high quality nutrients, right? So we need a certain amount of protein. We have essential fats that our body needs. We need vitamins. We need minerals. We need fiber. We need water. Um, we need these nutrients in order for our body to function properly. So any dietary intervention has to be supplying the essential nutrients that the body needs, and preferably in a healthy, whole form. The more we refine foods, the more we alter foods, and we take out some of those vital nutrients or we change them in some way. For example, people say, well, I'm eating oatmeal because it's healthier. Well, I'm like, well, what kind of oatmeal are you eating? And if, many times it's this instant oatmeal that in order to make an instant, in order to cook something faster, you have to take the fiber out of it. And so in order to make this instant oatmeal, you reduce the fiber integrity, you add sugar to it typically, so it's really sweet. So they take something that's very healthy like oatmeal and make it very unhealthy through that processing. So it needs to be healthy, preferably in whole form as much as possible. We need physical activity. And physical activity, there's so many different types of physical activity. And so I really focus on what the patient's interested and willing to do. So if they like to walk, that's great. But you need to do some strength training as well. It can't just be walking activity. You need to work the muscles. And then for patients with lipedema, certainly water-based exercises are ideal in that they really help. That hydrostatic pressure really helps to get rid of the fluid. And we have to look at the why we eat. That probably influences people more than anything else than the what we eat. We eat because we're happy, we're sad, we're bored, everybody else is eating. It's a good day, it's a bad day. There's all sorts of reasons to eat, but the why we eat's important. Sleep is very important, that we need to get 7 to 9 hours of sleep or we increase our hunger levels. And then medications. So medications can be very helpful for decreasing appetite. The role, though, of medications that I try to emphasize is that the anti-obesity medications should be used to help you make the lifestyle changes you need to make, right? So when you cut calories, when you exercise more, and you create this negative energy balance, meaning you're taking in fewer calories than you're expending, you're going to be hungry. And the more weight you lose, the longer you're in that negative energy balance, the more hungry you get. We know that. That's just how our bodies are wired. And the purpose of medication is to counter that natural hunger that occurs when we calorie restrict.
Mhm.
And that way you can sustain it. It's not just a way to lose weight. You need to have those lifestyle components. Without it, you can lose weight, but you won't necessarily be healthier at the end of that if you're not getting the nutrients that you need.
I like that. It doesn't take lifestyle out of the picture. It leaves
Absolutely
life,
not. Yeah,
especially if you plan on going off medications in the future, you need to sustain it with those lifestyle changes. And I agree with you on eating as whole food as you possibly can. And micronutrients, I had a question about that. We don't like test a lot for micronutrients. Do you test for micronutrients?
mostly vitamin D, B12 would be the ones that I would, but those are the ones we're most concerned about in people that are calorie restricting. Thiamine can be a concern as well, especially if
One.
you're really calorie restricting or you're having some issues with some GI issues. Other ones are less likely. They can be, and certainly patients that have had some sort of bariatric surgery, they need to be checking their vitamin levels at least once a year, every year for life. Those deficiencies can occur at any time. But if you're taking a medication that's really suppressing your appetite a lot, like a GLP-1
Mhm.
type medication, then you can become nutrient deficient. So then I might look for nutrient deficiencies. You know, occasionally zinc, but that's not really something that I look for all that often. But it is something I usually, if people are struggling to eat, I like them to take some sort of vitamin supplementation just to make sure they're not nutrient deficient.
So I'm going to jump to one of the questions, but I want to come back to GLP-1s, but I don't want to not answer this question. So this is a question from Tammy Farrer. She says, with increased sugar or carbs and increased insulin, fat cells swell per Dr. Ben Bickman out of BYU. What are your thoughts?
So they do. I mean, insulin is a storage hormone. It's very effective at getting glucose out of our bloodstream. Um, but how does it do that? It does that by, you know, it does that by storing it, right? So it can store it in the liver in a form of what we call glycogen. That's how we can kind of store glucose, but it promotes fat storage. So it takes circulating fat because our body will convert a certain amount of our food to fat. Either the fat we consume or excess sugars get converted to fat when we consume enough of it, and even some carbs. And so our body will be moving that into our fat cells. And so insulin is one of the mediators that helps the fat cells store fat. It promotes that storage of fat, and it prevents the fat cells from breaking down fat. So it inhibits something called hormone-sensitive lipase, which is a something inside our fat cells that breaks it down and causes fat to be released into the bloodstream. When insulin goes up, that shuts down. And so those are some of the ways that insulin will promote fat growth, fat storage, and promote increase in body weight.
And so that would be a hypertrophic fat cell. And I was just reading through the literature on the bigger the fat cell, the more water it holds. I mean, just because that's just the way it is, even though it doesn't hold a lot of water. So I'm not sure if Tammy meant that by swelling, but I would assume swelling means hypertrophy along with the accompanied increase in water. So let's come back to the GLP-1s because they are a game changer. Would you say they were a game changer for your practice?
Oh, totally. Totally. They really, they just have such a potent effect on appetite. And I think that's really much more than anything we've ever realized that people say, I'm just not thinking about food anymore, and that something that really has come out of this is a recognition of food noise, where people are thinking, you see that in some people, but it really just was manifested now. People who would, think about lunch at breakfast, think about dinner at lunch, and then think about breakfast the next day at dinner, and just always thinking about their next meal and thinking about snacks and thinking about nighttime eating. And these are are thoughts that can consume people. And then when you go on, if you try to calorie restrict and you go on a diet, the physiologic response, as I said, is to increase hunger signals, decrease fullness signals, so that food noise gets louder as you're following a calorie restricted diet. And the longer you're on that diet, the louder it gets, and the more intense it gets, and the harder it is to resist. And so it's not a good feeling, right? To feel hungry.
No.
A joke we have a term for it. We call it hangry, right? It affects our mood. It affects the way we feel. So, and so as I said, the GLP-1s or all the anti-obesity medications are there to help you turn down that food noise, turn down the natural physiologic hunger that occurs when you calorie restrict, so that you can make those healthy lifestyle changes and sustain them.
But they do so much more than that too, right?
Oh, they do. I mean, that's just the sort of the tip of the iceberg. That's
Yeah.
really what got them approved. If you want to go into some of the added benefits, they're numerous. We see, and some of that is that anti-inflammatory effect. So the first GLP-1 that got approved for something other than obesity and diabetes was semaglutide, that it got approved for patients with cardiovascular disease because it reduced their risk of a future cardiovascular event by 20%. I mean, that's better than a statin in terms of its effectiveness of reducing a subsequent cardiac event. Um, and one of the things that is interesting in that data is if you look at HSCRP, which is used as a marker for cardiovascular disease, high sensitivity C-reactive protein, that went down 50% in patients on the medication compared to placebo. That was amazing. That was a huge drop. And so that speaks to their effect on inflammation in the body. And that is what we see in women with lymphedema, that their legs feel better, right? They're not as swollen. They're not as sensitive. They don't feel, they don't ache as much. They don't have as much pain. I think that's a reduction in inflammation in that tissue. And so I think that's one of the where we're seeing a benefit that is outside of that. But other benefits of these, we've seen it with sleep apnea, although I think that's probably more weight related. We see it with fatty liver, and that's most likely related to improvement in insulin resistance that's occurring. But we're seeing a decrease in cravings for things like alcohol.
Yeah.
That people don't have a desire to drink on the medications like they did. I even had one patient who didn't enjoy shopping anymore. So she, I'm like, well, that could pay for the GLP-1 by itself.
So, MJ Tolles is asking what medication reduces cardiovascular risk, and that was the semaglutide or the
Yeah.
Ozempic or Wegovy.
Ozempic and Wegovy are the
Yeah.
brand names for that.
So, so we've got a reduction in appetite, a reduction in food noise, a reduction in inflammation, and a reduction in fat in areas where it shouldn't be, like the liver. What about muscle? Does it reduce ectopic muscle fat?
So yes, it does, right? So when you're losing weight, and I think this is this was really sort of magnified in the media about muscle loss with these medications.
Mhm.
Um, but the truth is, we've always known that when you lose weight, you're going to lose muscle as well as fat. In fact, there's something called the Heimsfeld rule after Steve Heimsfeld, which says that you lose when you're losing weight, about 25% of that is going to be muscle on average. So that means for every 3 pounds of fat you lose a pound of muscle.
Wow.
Now, it's muscle mass that's reduced, right? So in obesity, muscle mass is made up of the muscle, skeletal muscle tissue, and fat, right? Fat gets deposited in there. So how much
Absolutely.
of that is actual lean muscle loss is a little less clear. So
Okay.
muscle tissue size can change. Um, but that's universal. And I think it's more that these medications had such a dramatic impact on weight that their muscle mass went down so much rather than a dramatic impact on muscle itself.
Okay.
But it's still a concern. And, we worry about frailty. Losing weight and becoming frail does not improve your health risks, right? That's going to increase your health risks. So we have to be concerned about frailty. And that's why adequate protein intake is really important, that you want to be taking typically about 1.2 to 1.6 grams of protein per kilogram. That translates for most people somewhere between 80 and 120 grams of protein a day is usually kind of what you should target depending on your size. And you want to make sure that you're doing some resistance training because that protein without resistance training is going to make you vulnerable to muscle loss. And this is particularly concerning in women with lipedema because they already have muscle tissue that is either less in quantity or lower in function than other women. And I think that is also a kind of an interesting area of research. But um, I think it's particularly concerning as women with lipedema tend to lose muscle strength over time, even with exercising. So that's an area of concern. So now that, I think that's really where some of the exciting research is in what may be coming down the pike as well to help preserve that
Oh
muscle.
yeah, that's true. So, I want to get to that, but let me just ask you, do GLP-1 receptor agonists reduce fibrotic tissue? That's a question I get a lot and where people say, well, I know it's going to reduce my regular fat, but not my fibrotic lipedema fat or not my, not the fat around my waist because it's so fibrotic. Do you see a reduction in fibrosis with the GLP-1 agonists?
So I don't usually see a reduction in lipedema tissue itself. In
Okay.
fact, one of the things that's kind of interesting is that many women will say that their lipedema tissue is more sensitive to touch now. And so the size of their legs may go down, but I think it's because they're losing the generalized excess fat that's in their legs and not the lipedema fat. And now you're taking away a little bit of a cushion that might have been insulating that lipedema tissue from direct contact, and being sensitive to touch. And so that many women will say it hurts more, it's more sensitive to touch, or I'm having a harder time like lying on my side because it seems to be more sensitive. Is that something that you've
Yeah.
experienced or heard from your patients, Karen?
Yeah, I've seen it in lipedema and also Durkheim's disease.
Yeah. Yeah. So I think when you see a reduction in size in those areas around the abdomen, around the hips and the buttocks and the legs and the
Mhm.
arms, it's going to be the generalized adiposity.
Mhm.
Um, which if you're planning to go for surgery, I think it's good to get rid of as much of that tissue as possible, because then the surgeon can really focus on the lipedema tissue.
Yeah.
And you're not taking you can take a lesser volume of tissue, but more lipedema tissue.
Yeah. Yeah, I've been trying to come up with all sorts of things that reduce the fibrosis to make it easier for weight loss to occur, for surgery to happen. And I use things like enzymes to chew up the fibrotic tissue, deep tissue therapies. And there's a lot of research now in the literature on shockwave therapy. So those are things that I'm looking to. And I just bought a shockwave machines. I'm gonna start playing around with that.
Yeah.
Um,
But it doesn't seem to be the GLP-1 doing that.
Okay,
Yeah,
yeah,
that's
that's
not been my experience. I don't know if you've have seen otherwise.
well, I think that we're not looking for it. We don't have a good way of quantitating fibrotic
Right.
tissue. And so no one's really looking at it over time. So I kind of rely on what my patients tell me about their tissue.
And
And
that's my experience too. Yeah.
yeah, and that's unfortunate that we don't have a good fibrosis meter to
Mm,
follow people with. And I know you can use some ultrasound techniques, but those pieces of equipment are very expensive
mm.
and not many people have them. So we have to come up with something else. Um, this is let's see. Um, just to this is going back to just looking at inflammation in general. If if you were mentioning like eating whole foods and healthy foods without chemicals or processings, Susan Antley asked, how can testing be done for foods that trigger inflammation?
Yeah. Well, I don't think we have any way of quantitating that. We have way of testing allergic response, but not really an inflammatory response. But one of the things I tell women is to listen to your legs. I find the frustration with lipedema, the long-standing just kind of pain and discomfort. It's one of the ways of coping with that is to dissociate, right? To say they're not there. I'm just not going to pay attention to them. They always hurt, so why do we even think about them, right? And so you just try to pretend it's not there. Not that you can, but it just, I feel that they become somewhat disconnected from listening to their legs. And then when, they may go on a low carbohydrate diet, suddenly their legs feel a lot better. And I'll ask them, if you go off your diet at all and you eat some extra carbs, do your legs feel different? And very often they do. So I do believe that you can kind of test, and I think what's pro-inflammatory in one person may not be pro-inflammatory in another. So I think it's an individual response, but I think the most important thing is to listen to your legs and listen to see what makes them feel bad, what makes them feel heavier, what makes them feel swollen, what makes them feel more sensitive.
We did some research when I was at UCSD in San Diego, and we were looking at trying to figure out what foods were inflammatory. We looked at matrix metalloproteinase levels. And so if a food quickly generated an increase in what we call MMPs, then we knew that they were inflammatory. And then we could inhibit those enzymes using medications like tetracyclines, or we used grapeseed extract at one point, and that helped too. So I think I know they're working on that, but that's not quite available outside of research right now. And then there's the MRT food test, which also is not well substantiated in the literature. But if you allow food to interact with your immune cells and they shrink in size when they see a food, the thought is they're secreting out, releasing packets of cytokines and shrinking in size. So it's kind of a functional test. Those are the only two tests that I know. So neither one is like super fantastic.
And there's some 600 different adipokines that are released by fat cells. And so trying to just measure everything, it's really, that's a lofty task to, identify which ones are the ones that are causing the pain, the inflammation.
So if somebody was on a GLP-1 agonist, and let's say they lost all the weight they needed to lose, then what do? Do you continue on a GLP-1 for maintenance at a lower dose, or do you go off of it and maintain it by lifestyle? This is MJ Tolles asking that question.
So when we get to the maintenance phase, if you think about somebody that is you're treating diabetes, right? And you're putting them on insulin, and you're regulating that, and you take it up to a certain point. Now their insulin is well controlled, their blood sugar is well controlled, and then they start making some lifestyle changes, and their sugar starts coming down, and so you're going to decrease your insulin level, your insulin dosing, in order to adjust for that. So kind of using that concept, instead of measuring glucose, I monitor a patient's appetite, right? Because the medications are really there to regulate your appetite, to control that hunger that, as I mentioned, is a physiologic response to calorie restriction. So you've calorie restricted, your diet's now where it is. Are you having a hard time eating? Are you having a hard time getting enough calories in? If you're struggling to eat, I'm going to decrease your dose, because we're giving you too much, as if we were giving you too much insulin and your sugar is dropping too low. Same kind of concept. I'm going to start scaling back that medication to a point where your appetite is at a comfortable zone. You eat an appropriate amount of food and you feel full, and you stop. And so for some people, that means never changing the dose. For some people, they could come off of the medication. More likely, because it's a chronic problem, that increase in appetite. There's an interesting study done, published in this back in 2011 by Sumithran, that looked at these hunger and fullness signals in somebody who lost weight on a kind of sort of an intense diet for 10 weeks. They lost 14% of their body weight. And then they looked at those hunger and fullness hormones. And at the end of those 10 weeks, those hunger hormones were high, the fullness hormones were low. So at the end of the weight loss period, hunger drive was still high. But then they looked at it a year later, after a year of maintenance, the hunger level, the hunger hormone ghrelin was still higher, and the satiety hormones, the fullness hormones, were still lower 1 year later. And so that drive to consume, in fact, their desire to eat and perceived hunger was higher a year after the weight loss than it was after that 10 weeks. So hunger actually increased over the course of the year, even on that maintenance. So it's a chronic problem. And so some patients will always have that hunger. If you've always had food noise in your head, you're likely to always have food noise afterwards, after you lose the weight, and may even be more intense. And the medication's going to benefit you there. Some people don't have that. They may be eating healthier foods, or they're just not driven by that increased hunger. We all have different hunger levels.
Mhm.
And so if somebody's hunger level's always high, then they're going to need the medication. If they haven't been high and they lose the weight and they're and maintaining those lifestyle changes, and that's maintaining their appetite, then they don't need to take the medication, or they may be able to take a lower dose of the medication.
Nice. I've used microdoses of GLP-1s in very small people who have chronic inflammation and pain, and just those little small doses that they take can help them, and they just stay on those very low doses. And I would say that would be maintenance for them, because we don't know what's going on in their body. There's kind of like an auto-inflammatory type of a disease, and the GLP-1s are helping with that. And this is
Hmm.
this is definitely off label. So let's go back to some of these questions. So we are talking about how you would maintain some of the benefits. And this is from MJ Toll. She says, I have both lipedema and lymphedema. She agrees with weight loss, but there's more pain as a result. So with the GLP-1s, and she's been doing infrared sauna and cold plunges, as well as float therapies that are helpful. So
Hmm.
I kind of like that. That's a non-medication way of helping to maintain your health. And do you recommend cold plunges? Do you think that's helpful for anything related to what we've been talking about?
I haven't really used that. Float therapy has worked. I've had patients from a certain area that had access to that, and they found that to be very helpful. I haven't used cold plunges, so I can't really comment on that.
Okay. I mean, cold's an anti-inflammatory.
Hmm.
Okay,
Right.
so talk to us a little bit about what's coming down the pipe.
So yeah, I think the number of medications and the emphasis on future research in obesity medicine is really tremendous. So we've seen the GLP-1, we've seen now what we call the dual agonist GLP-1 GIP. And so they had different targets, right? But they affect appetite, but they also affect the body in other ways. And I think the real question is how are these agents going to affect the fat cells? And so the GIP has an added benefit over that the GLP-1 doesn't have, in that it promotes adipogenesis, which is the formation of fat cells. And so as you form these new fat cells, what does that do? Well, it doesn't sound like that would be helpful initially, right? It sounds like, well, you're getting rid of
Terrible.
more fat. That doesn't sound good. But the analogy that I make is say you have a dozen people that have to go up in an elevator, and you only have one elevator, you put 12 people in there. It's crowded, it's hot, everybody's uncomfortable, can be a little bit inflamed, so that could be a pro-inflammatory situation. Um, and so now take those 12 people and you have three elevators for them to go into. Then four people can go into each elevator. Everybody's going to be very comfortable. Well, that's how I describe the fat cells. In the fat cells, the greater the number that you have, then the less that they have to swell, right? So if you only have a certain number of fat cells and you overload them, they get swollen, they get inflamed. But if you can form new fat cells, well, then that fat can be distributed through those new cells, and they won't be overloaded, and they won't be inflamed, and they won't be pro-inflammatory. And so that is where I think some of the benefit comes with the GIP, because it promotes new fat cells. So you can have more smaller fat cells to share that same space. So the size of the tissue may not change, but if it's made up of more small cells, that's better than fewer large cells. Um,
Mhm.
and so that is how that can be of a benefit. Um, but we don't know all the benefits, right? Like I said, this anti-inflammatory effect, where is that coming from? Why is it doing that? Why is it lowering inflammation? And I think that's where the GLP-1, the semaglutide, or Ozempic type medications are having a benefit, not so much in changing the size, changing the number of cells. It doesn't do that, but it reduces the size that reduces the inflammation.
Yeah.
And so I think that is a benefit. The There's another receptor called glucagon, which is something that glucagon is something the liver makes that helps to increase our glucose, put more glucose into the bloodstream. And so these glucagon receptors also, though, are affecting appetite as well, and they affect fat storage in the liver. And so these glucagon receptor agonists are really going to be very beneficial for the fatty liver disease. But is it going to have another effect on lipedema tissue? Don't really know. We didn't expect all these other effects from GLP-1 and GIP. So we'll have to see. There doesn't seem to be significant glucagon receptor activity on the fat cells. So I'm not sure that's going to be a big difference, but there are these combined GLP-1s and glucagon receptor drugs that are in the market, and there's another drug called retatrutide, which is a GLP-1 GIP glucagon triagonist. So it's got triple activity. That showed 25% average weight loss in phase 2 trial. So that's in phase 3 now. We'll see what happens with that. But another area that I think is going to be interesting is these monoclonal antibodies that increase muscle mass. And so there's a medication called bimagrumab, is one that's being looked at now. And this monoclonal antibody works on the actin receptor, which actin decreases muscle strength and activity. And there's some evidence that there's crosstalk between the lipedema tissue and these actin receptors that may be decreasing or increasing actin activity, which contributes to the weakness in the muscles. And so these block actin, and what we see some weight loss with these medications, but what's really interesting is we see big drops in fat mass, but increases in muscle mass. So the scale doesn't change as much, maybe about 8 to 9%, but the body composition changes a lot. And I think that is something that's very interesting to me. So they've been um, they were supposed to release the data. I haven't seen it on the combination of semaglutide and bimagrumab, but they're also looking at it with tirzepatide and bimagrumab, which is the Zepbound Mounjaro medication. So I think that could be very interesting. And there's other actin receptor blockers that are in the pipeline as well that are being looked at. So that's another area of interesting research.
That'll be great for aging and frailty. My goodness. I mean,
It is.
the aging market is huge.
It is. It is. Now, they did do a study in elderly with bimagrumab and didn't see a change in muscle function. It was a limited study though, but it kind of put a kibosh on, put kind of caused them to shelf it for a short period of time, and then they resurrected it to see if they could use it in combination with GLP-1s.
Okay.
I think that pathway is going to be very helpful for looking at potentially countering some of the negative effects in muscle mass of weight loss, but there may be particularly a benefit in women with lipedema.
Yeah, that sounds really exciting. So you mentioned fatty liver. How many people have fatty liver? How important is that to our population?
Yeah, so it's estimated that around 1 in 4 people have fatty liver. Um, Now, this is really driven, the fatty liver is driven by insulin resistance.
Mm.
So it would see it more commonly in patients with diabetes, but any kind of obesity. So what ends up happening is the body, when when those normal fat cells get overloaded, the fat has to go somewhere. And particularly if you have a lot of abdominal fat, that visceral fat, that fat feeds into what we call the portal system. That's the system that returns blood from the intestines into the liver, where the liver can first process everything, all the nutrients we have and so on. But it also gets exposed to a lot of fat by those fat cells around the belly, uh, releasing it into the portal system, and then it lands and gets stored in the liver and builds up fat in the liver. And so the increase in belly fat is associated with increase in fatty liver and fatty liver disease. And the problem with that is, some fat in the liver is not the problem, but over time, that inflammation from that fat causes fibrosis of the liver and eventually cirrhosis of the liver and liver failure. And so now fatty liver is replacing hepatitis C as the leading cause of liver transplants. And it also increases the risk of forming hepatocellular carcinoma, which is a consequence of that cirrhosis, that you can get cancer of the liver.
And how do people find out if they have fatty liver? Can you just look at a lab test?
So there's something called a FIB-4 score, which is a calculation that's done. If you look up FIB-4, it's based on your liver enzyme tests, your platelets, and your age. And so it's a simple calculation that can be used to see whether you're at risk for liver fibrosis. The testing for it, there's another blood test that can be done, called Enhanced Liver Fibrosis Score, which is a series of tests that can be done. Or you do an ultrasound scan that looks at the elasticity of the liver. So it's a vibration scan that sees how stiff the liver is. And from that, they can calculate whether you have liver fatty, or whether you have fibrosis and fatty liver disease.
And people could just go get a simple ultrasound of the abdomen to find out if they even have the start of fatty liver, right?
Yeah, it's not a very sensitive test. So when you look at ultrasounds, it can be missed a lot just on ultrasound. People commonly find out about it because it's incidentally reported on a ultrasound when they see it. So when they see it, it's a good marker, but it's not a good screening tool because it'll miss a lot.
Yeah, and if you have any kind of hemochromatosis or iron deposition in your liver, they can read that out as fatty liver as well and ignore it.
Yeah.
So yeah, but at least there is some testing that people can use to find out if they have fatty liver. So we've talked
Yes.
about, I think, fat in every single location except for the brain. We can skip that, but
Where it's very helpful, actually.
but GLP-1s are being used for the treatment of dementia, right? Alzheimer's.
Yes, that's another pathway that really looks very exciting.
Yeah.
We could literally go on for another whole hour. And it's a good thing I wasn't on camera, Dr. Herbst, because I was literally nodding my head off. It was such a fascinating conversation. And I loved our chatters, our questioners, our audience. You're amazing. I love how you support each other. And Dr. Pennings, thank you for devoting your career. What made you decide to focus on obesity? I gotta know.
Well, I've always been focused on health and wellness. It's always been part of my career. I pursued osteopathic medicine because that is a bigger focus in osteopathic medicine. I was actually very interested initially in smoking cessation. My father died of lung cancer, so it really made me passionate about smoking cessation. But I also found out, smoking rates went down, obesity rates went up, and people smoke and eat for the same reason, right? They're happy, they're sad, they're bored, everybody else is doing it. And so a lot of the tools I learned for smoking cessation actually applied very well for obesity. But what really excited me about obesity was that when I help people lose weight, I help them get healthier. I'm taking them off of blood pressure medicine, off of cholesterol, off of diabetes medicines. They feel better, their energy levels better. And that's what I became a doctor for, because I wanted to help people get healthy, not just treat disease.
That's so beautiful. We're so happy. That's why Lympha Press does what it does, because we love to help people get better and improve their quality of life. By the way, if you have joined us tonight, you're not familiar with Lympha Press, go to lymphapress.com. We would love to help you. Any closing words, Dr. Herbst?
It's been such a pleasure. I love fat, and so talking about fat with you tonight was the best. And and you're right, Brenda. There's so many more questions I have, and I hope our audience enjoyed the talk tonight. We'd love to have you on again in the future.
I'd
Yes.
love to be here. Thank you for having me.
And the GLP-1 didn't help me stop shopping. I will say that. With that,
Okay.
thank you all for joining us tonight. We will see you next month for another riveting discussion led by Dr. Herbst. We appreciate you all, and especially you tonight, Dr. Pennings. Have a great night, everybody. See ya.
Bye-bye. Thank you.
Bye.